Welcome to the Funnel Effect. Today, we're diving deep into one of the most challenging, complex, and often elusive diagnoses in modern cardiology, cardiac sarcoidosis, or CS. This condition is a formidable infiltrative cardiomyopathy. It can, well, masquerade as many other common heart issues, but timely and accurate management is absolutely critical. We're talking preventing catastrophic outcomes like sudden death or end-stage heart failure. The roadmap for our discussion today is the definitive diagnosis and management of cardiac sarcoidosis, a scientific statement from the American Heart Association. It's a monumental piece of work, really, providing much-needed guidance where clinical certainty is often, well, rare. And we should absolutely acknowledge the authors. Our sources are anchored by the work of Richard K. Chang, MD, MSc as chair, Michelle M. Kittleson, MD, PhD, FAHA as vice chair, and their colleagues, including Craig J. Beavers, PharmD, FAHA, David H. Burney, MD, Ron Blankstein, MD, Paco E. Bravo, MD, Nisha A. Gilotra, MD, Mark A. Judson, MD, Kristen K. Patton, MD, FAHA, and Leonie Rose Bovino, PhD, APRN, FAHA. This was on behalf of the American Heart Association, Heart Failure and Transplantation Committee of the Council on Clinical Cardiology, and the Council on Cardiovascular and Stroke Nursing. Quite a team. So, the mission for us today is to unpack the genetic, imaging, and therapeutic complexities they've outlined. The core problem, the one they tackle right up front, is this realization that definitive histological confirmation of CS is elusive. Instead of a simple yes or no diagnosis, clinicians have to navigate a continuum of likelihood. Expert, let's start right there. Why is this idea of a continuous spectrum rather than just a binary diagnosis maybe the most important clinical takeaway here?
That's a great place to start. It's fascinating because the AHA statement really leans into this diagnostic uncertainty from the get-go. Medicine usually prefers a clear yes-no answer, right? Especially for a disease where the treatment involves potent immunosuppression. But cardiac sarcoidosis just doesn't play by those rules. We define CS as an infiltrative cardiomyopathy. It's caused by granulomatous inflammation building up in the heart muscle itself, an active inflammatory process. But because the disease is so patchy and it's so difficult to actually get a piece of the heart via biopsy that shows the problem, the diagnostic process forces us to rely on the sort of weight of accumulated evidence, not just one single test.
So it's really a pragmatic necessity then. If you wait around for that perfect definitive biopsy result, well, your patient might have a fatal arrhythmia in the meantime.
Precisely. And the disease typically shows up in one of three major and potentially life-threatening ways. First, high-grade conduction disease that means severe heart block. Second, ventricular arrhythmias or VAs. Those are abnormal, often dangerous heart rhythms originating from the ventricles. And third, left ventricular dysfunction, which leads directly to heart failure.
And those three presentations are exactly why diagnosis is so tough, because they're not specific.
Exactly. They're incredibly nonspecific. They can be caused by coronary artery disease, other types of cardiomyopathy, even genetic syndromes. This lack of specificity is precisely why the statement moves away from a simple binary decision. They recommend viewing the likelihood of CS along this spectrum: definite, highly probable, possible, low probability, or unlikely.
Okay, so this continuum framework forces clinicians to become synthesis experts, essentially. You have to integrate all the data you have, imaging, clinical symptoms, any pathology to assign a probability. And crucially, this allows you to initiate treatment sooner, maybe even if you never get that positive biopsy.
That's exactly right. And that leads us directly into the treatment context. A key driving force behind this whole scientific statement is the significant variation in treatment approaches you see across different medical centers. The source material really calls this out. Treatment, primarily high-dose corticosteroids as the first line, is usually initiated for those who are symptomatic and show active inflammation on imaging.
And the underlying problem driving that variation is the lack of large-scale randomized clinical trials or RCTs to really define the ideal drug or the right duration.
Yes. Without those big RCTs, centers are currently relying heavily on smaller cohort studies and, frankly, consensus opinions. And that's led to this significant variation in practice.
So the need for a unified framework was urgent.
It really was. That variation underscores the urgent need for a standardized diagnostic and management approach, which this AHA statement aims to provide. We're dealing with a disease where morbidity and mortality are distressingly high. Timely, standardized management is absolutely essential, even if the diagnosis itself carries some inherent uncertainty. #tag2, pathophysiology and epidemiology.
Okay, so we've established diagnosis is inherently uncertain, forcing us onto this spectrum of likelihood. Before we dig into how advanced imaging helps navigate that uncertainty, let's step back a bit. Let's understand the basic biology. What exactly is this mysterious immune attack doing to the heart tissue itself?
Well, the exact cause of sarcoidosis remains one of the great unknowns in medicine, honestly. But the most common and probably the most robust hypothesis points toward a kind of perfect storm scenario. It seems to involve environmental exposure interacting with a genetic predisposition.
An environmental trigger in someone who's susceptible.
That's the working theory. Exposure to some unknown environmental antigen, the source material mentions things like mold, silica dust, maybe even insecticides, triggers an abnormal immune response, but only in a genetically susceptible host. It's like a localized, uncontrolled immune system reaction.
And the genetic connection seems pretty strong, right? Genome-wide studies keep pointing towards susceptibility linked to specific immune markers, especially those HLA class II alleles.
They certainly do. It emphasizes that familial and racial predispositions are really key factors when you're thinking about risk stratification. Now, the fundamental mechanism of damage involves a dysregulated T-cell immunological response. We see an activation of type 1 T helper cells, or critically, an impaired regulatory T-cell response.
So the immune system turns on the attack.
Right.
But the brakes, the things that should shut it down, fail to engage properly. It's like an immune runaway train.
Precisely. A good analogy. This relentless immune dysregulation leads to the activation of specialized white blood cells called macrophages. These macrophages then clump together, aggregate, to form those characteristic non-caseating inflammatory granulomas. That's the hallmark lesion. That's the active FEMs of the disease.
And this process causes damage in two ways.
Yes, it's a dual damage mechanism. First, there's the acute tissue damage caused by the active inflammation itself, the granulomas invading and disrupting normal tissue.
Yeah.
But eventually, over time, that inflammation can transition into a fibrotic phase. It gets replaced by scar tissue. The AHA statement highlights that both the active inflammation and the resulting fibrotic scar contribute to cardiac dysfunction.
So whether it manifests as heart failure because the muscle is destroyed, or life-threatening arrhythmias because the scar tissue messes with the electrical pathways, both stem from this process.
Exactly. Inflammation and fibrosis are the two key culprits.
Okay, let's talk a bit about the patterns of the disease, epidemiologically speaking. The prevalence of systemic sarcoidosis in the U.S. is cited at about 35 cases per 100,000. And it seems clustered, mostly urban areas, particularly the East Coast.
That's the general pattern for systemic disease. And we absolutely must recognize that the prevalence of CS specifically, cardiac involvement, seems to have increased dramatically over the past few decades.
But that's not necessarily a true rise in the disease itself.
Probably not.
Right.
It's much more likely due to a profound shift in our ability to detect it, better awareness among clinicians, and frankly, much, much better diagnostic tools.
I found that statistic from Finland just staggering. A 20-fold increase in the annual detection rate of CS between 1988 and 2012.
That 20-fold jump is hugely reflective of historical misdiagnoses. Think about it, for decades, clinicians were likely looking at patients with unexplained high-grade heart block or sudden cardiac death in younger people and just labeling the cause as idiopathic. They didn't realize they were missing this specific, potentially treatable inflammatory process.
Until advanced imaging came along.
Right. Advanced imaging, especially the widespread adoption of cardiac MRI, CMR, and PTT scans, finally gave us the magnifying glass we desperately needed.
And we also see significant racial and sex variations in how the disease presents itself. The sources highlight that systemic sarcoidosis overall is more common in Black Americans and in women.
Correct. And when you look closer at the cardiac phenotype, there are some reported differences too. Symptomatic heart failure seems to be noted more often in Black individuals and in women, whereas ventricular arrhythmias seem to be reported more frequently in men. There's also that interesting observation about CS being particularly prevalent in the Japanese population. These kinds of differences really underscore the complex, multi-layered role that genetic factors likely play in determining not just susceptibility, but the specific way the disease manifests clinically. Hashtag tag-free3. Clinical manifestations and red flags.
Okay, so for most people, when they hear sarcoidosis, they think lungs. And that's true, right? Up to 90% of systemic cases involve the lungs.
That's correct. The lungs are the most common site by far.
But when sarcoidosis decides to attack the heart, even though that's rarer, clinically manifest CS is only seen in about 5% of systemic cases. The implications are far, far graver.
That 5% carries a disproportionately huge burden of risk. And while a larger percentage, Maybe around 20% of patients with systemic sarcoidosis might show some subtle cardiac involvement if you look closely with advanced imaging.
Right.
It's the clinically relevant symptomatic manifestation that really drives the mortality and morbidity.
So let's focus on the clinician perspective. If you're seeing a patient who does not have a known sarcoidosis diagnosis, what are the absolute must not miss red flags that should immediately make you think, could this be cardiac sarcoidosis, and push them onto that continuum of likelihood?
The AHA statement provides three very strong sort of non-negotiable indicators. The first one is unexplained high-grade atrioventricular AV block. Especially in an individual who is relatively young, the guideline uses the cutoff of under 60 years old.
Okay, so serious heart block in someone under 60 should ring alarm bells for CS.
Absolutely. It should always raise immediate suspicion for an infiltrative or inflammatory process like CS, rather than just age-related degeneration. The second red flag is unexplained ventricular arrhythmias, VA. These are inherently dangerous rhythms, and if you can't find another cause, CS has to be high on the list. And the third involves specific echocardiographic findings, things like a reduced left ventricular ejection fraction, LVEF, or maybe a regional wall aneurysm, or sometimes this characteristic thinning of the basal septum.
But the key is unexplained, right? These findings only count if there's no coronary artery disease or other obvious reason for them.
Precisely. You have to rule out the common things first. If those echo findings exist without another clear explanation, then CS becomes a strong suspect.
And the way it presents clinically depends entirely on where in the heart the inflammation decides to set up shop.
Absolutely. The disease is like a geographical disaster inside the heart. If the granulomatous infiltration primarily targets the basal interventricular septum, that's where the critical electrical conduction system lives, then you're likely to get a high-grade heart block. If, on the other hand, you have widespread inflammation and subsequent fibrosis throughout the myocardium, the heart muscle itself, then you're more likely to see systolic dysfunction and eventually heart failure.
And the scar tissue itself becomes the problem for arrhythmias.
Yes, that scar tissue, the fibrosis, becomes the substrate. It disrupts the normal electrical pathways and creates reentrant circuits that can trigger those fatal ventricular arrhythmias.
Okay, now here's where it gets really interesting and significantly complicates the diagnosis. Isolated CS. The statement points out that a substantial proportion, maybe 49% to 65% of cases, initially present with only cardiac manifestations.
Yes.
So no clinically evident extracardiac involvement, no lung lesions on chest x-ray, no swollen lymph nodes you can easily biopsy, just the heart problem.
This is a diagnostic nightmare, honestly. If you lack that confirmatory biopsy evidence from an easier-to-reach organ like the lung or a lymph node, you're forced to rely almost entirely on those clinical red flags and the advanced imaging findings. You spend valuable time ruling out dozens of other conditions. The high incidence of isolated CS is precisely why the shift towards multimodality imaging has become so absolutely critical.
Makes sense. What about screening then? Let's say I have a confirmed case of sarcoidosis elsewhere in my body, maybe my lungs, but I feel perfectly fine from a heart perspective, and my initial cardiac workup was normal. Should I be getting regular cardiac scans just in case?
That's a really practical question. Current guidelines actually recommend caution here. Routine cardiac surveillance, like yearly echoes or scans for completely asymptomatic individuals with known extracardiac sarcoidosis (ECS), is generally not recommended.
Yeah.
However, the level of vigilance needs to remain extremely high. CS can absolutely manifest years, even decades, after the initial sarcoidosis diagnosis. So any new unexplained symptom palpitations, sudden shortness of breath, feeling lightheaded or fainting must prompt a full, thorough cardiac assessment immediately. No delay.
Because catching it early allows for more timely treatment.
Exactly. Earlier identification means you can potentially initiate immunosuppressive therapy when the disease is still in that active inflammatory phase, which might be more reversible before extensive scarring sets in.
All right, so we've established that the standard tools like ECG and echocardiography, while useful, they often lack the necessary sensitivity for a disease that's so patchy and can be quite subtle early on.
That's right. They give clues, but rarely the whole picture.
So the heavy lifting in diagnosis really falls to two highly advanced and importantly complementary imaging modalities, cardiac magnetic resonance, or CMR, and fluorine-18 fluorodeoxyglucose positron emission tomography, or FDG-PET.
These two are absolutely fundamental now. They serve distinct, yet really interconnected roles in diagnosing and managing CS.
How would you describe those distinct roles simply?
Okay, if we think of CS as a sort of smoldering fire within the heart muscle, CMR is brilliant at mapping the structural damage and the aftermath, the scar tissue, the fibrosis left behind by the fire,
Hmm.
whereas FDG-PET is designed to detect the active fire, the ongoing metabolically active inflammation itself.
Scar map versus fire map. I like that. Hashtag A. Cardiac magnetic resonance imaging, CMR, mapping the scar. Okay, let's start with CMR, the scar map. It primarily uses something called late gadolinium enhancement, or LGE, to highlight fibrosis. Can you walk us through how that LGE technique actually works? How does it make scar tissue light up?
Sure, gadolinium is used as an extracellular contrast agent. When you inject it intravenously, it goes into the bloodstream and then diffuses out into the interstitial space, the space between the heart muscle cells. Now, in healthy, normal heart muscle, this contrast washes in and then washes out relatively quickly. But in areas where there's fibrosis, scar tissue, or even significant active inflammation, basically,
Yeah.
the areas damaged by the granulomatous attack, the extracellular space is expanded. There's more room between the cells.
Okay.
Because of this expansion, the gadolinium contrast agent gets trapped or washes out much more slowly. So when we take images of the heart maybe 10 to 20 minutes later, that's the late phase, this retained gadolinium creates a bright, intense signal on the MRI. That bright signal is the LGE, and it essentially outlines the areas of structural damage.
And the performance data looks pretty convincing. The statement mentions a meta-analysis showing CMR had high sensitivity, around 95%, and specificity, around 85%, for diagnosis when used alongside clinical findings.
Yes, it's a powerful diagnostic tool. But I'd argue the true power of CMR in CS, the real game changer, is its prognostic value.
Ah, okay. So not just if you have it, but what's likely to happen because you have it.
Precisely. The presence and pattern of LGE is cited as the single strongest predictor we have for all-cause mortality and for sustained ventricular arrhythmia. And what's really practice-changing is the insight that that pattern and the mere presence of that scar often matter more for future risk than the overall pump function of the heart, the LVEF.
Now, that is a critical point. LGE as an independent predictor of VA and death, separate from LVEF, because, as cardiologists, we're so hardwired to look at the LVEF, the ejection fraction, the pump function, and use that 35% cutoff as a key threshold for things like ICDs.
Exactly. And what this AHA statement, based on accumulating evidence, forces us to do is to look beyond just the pump function. We need to recognize that even a heart that seems to be pumping strongly, maybe with an LVEF of 55% or 60%, can harbor a massive electrical risk if the underlying tissue composition revealed by that LGE scar is abnormal and located in a critical electrical pathway.
So you can have a strong pump, but with a potentially fatal short circuit hidden inside.
That's a perfect way to put it. And researchers have identified specific locations within the heart where CS damage commonly occurs. They call these pathology-frequent LGE patterns.
Right. Tell us about those.
These patterns, which are seen in over 90% of pathologically confirmed cases, typically involve areas like the subepicardium of the left ventricle, the outer layer, the interventricular septum, the wall between the ventricles, sometimes multifocal spots throughout the LV, or even involvement of the right ventricular free wall. And crucially, when researchers studied patients, they found that having one of these specific pathology-frequent LG patterns was associated with a significantly high risk of arrhythmic events. And importantly, this risk was independent of the patient's LVEF and also independent of the total amount or extent of the scar. Just having it in those locations was bad news.
Wow. That fundamentally changes how we should be risk stratifying these patients. We're not just waiting for the heart muscle to fail globally. We're actively looking for these specific electrical fault lines indicated by the scar pattern.
It's a paradigm shift. However, we absolutely must stress the limitations of CMR too. No single LGE pattern is completely pathognomonic meaning, sufficient for a definitive diagnosis all by itself. Other diseases, like prior heart attacks or other cardiomyopathies, can sometimes mimic these scar patterns.
Okay.
And perhaps even more critically, the absence of LGE does not fully exclude CS.
Why is that?
Because you might be catching the disease very early on. The active inflammation might be present, but just hasn't had enough time to transition into that permanent detectable scar tissue yet. The fire is burning, but the scar hasn't fully formed.
Which leads us perfectly to the need for the other tool, the fire map. Hashtag B, cardiac FDG-PET detecting active inflammation.
Right, so CMR gives us the structural damage map, the scar. FDG-PT gives us the activity map, the fire. How does FDG-PT actually pinpoint that active metabolically burning inflammation? Okay, so FDG-PE uses a tracer called fluorine-18-fluorodeoxyglucose. FDG is essentially a glucose molecule with a radioactive tag attached. Now, Activated inflammatory cells, primarily those macrophages and lymphocytes that form the granulomas, have a profoundly upregulated glucose metabolism. They
Yep.
are hungry for glucose. They use special transporters, actually insulin-independent transporters, which means they rapidly suck up this FDG tracer, much more so than surrounding quiescent tissue.
They light up because they're metabolically hyperactive.
Exactly. They light up brightly on the PT scan, revealing the sites of active inflammatory lesions. This makes PT absolutely crucial for assessing disease activity as the fire currently burning, and subsequently for monitoring how well treatment is working to put that fire out.
But there's a catch, isn't there? The heart muscle itself normally loves glucose. That seems like it could cause problems with interpreting the scan, maybe lead to false positives if the normal heart activity masks the specific inflammatory signal.
That is the critical challenge with cardiac PTT for inflammation. And it's why the patient preparation protocol is arguably just as important as the scan itself. If the healthy heart muscle is also avidly taking up glucose, the entire ventricle will just glow bright on the scan, potentially drowning out those smaller, localized inflammatory spots we're looking for.
Right. You need to quiet down the background noise.
Precisely. We need to turn down the volume on the normal heart's glucose signal so that the inflammatory fire, the signal from the granulomas, can be clearly seen or heard, so to speak.
And how do we achieve that? We hear a lot about this special prep inducing a metabolic switch.
That's the key. We essentially need to starve the healthy heart muscle of its preferred fuel, which is carbohydrates, glucose, for an extended period before the scan. This usually involves a minimum of 24 hours, but often optimized protocols use up to 72 hours. During this time, the patient follows a diet that is very low in carbohydrates and rich in lipids, or fats basically, a ketogenic diet. This forces the healthy myocardium to switch its metabolic engine over to using fatty acids or ketones for energy instead of glucose.
But the inflammatory cells are stuck on glucose.
Exactly. Those hyperactive macrophages, they're sort of locked onto using glucose regardless of the dietary changes. So only they will still avidly absorb the FDG tracer and light up against the now quiet background of the healthy heart muscle. This strategy, when done well, achieves up to 95% success in suppressing that normal myocardial FDG uptake.
Okay, so assuming successful prep, what are the hallmark findings on the PE scan that scream cardiac sarcoidosis?
The most characteristic finding is multifocal FDG uptake bright spots scattered in different areas of the heart muscle. This becomes even more specific if that FDG uptake corresponds to areas where there are resting perfusion defects, seen on the PET scan, what we call a perfusion metabolism mismatch. It means an area isn't getting normal blood flow and it's actively inflamed. Or, another very strong sign, is finding FDG uptake in the heart in combination with active extracardiac inflammation elsewhere in the body, like in the lungs or lymph nodes, seen on the same scan. That confirms systemic disease activity involving the heart.
But just as CMR has its limitation, the disease might be too early to form scar. PET has its own potential limitation, the burned out issue.
Correct. You can have definite cardiac sarcoidosis, confirmed by biopsy even, but have a negative FDG PT scan.
How does that happen?
It happens if the disease process has progressed entirely to the fibrotic phase. If the active granulomas have completely resolved or been replaced by metabolically inactive scar tissue, there won't be any significant myocardial FDG uptake. The disease is still structurally present, the scar is there, but the active inflammatory fire is out. Only the ashes, the scar, remain.
Which is precisely why the two modalities, CMR and PE, are so complementary.
Absolutely. You need both perspectives, the scar map and the fire map, for a complete picture. This is why, if the clinical suspicion for CS, the pretest probability, is high, clinicians will often pursue both CMR and FDG PET, sometimes even on the same day.
And the diagnostic power when they work together is pretty impressive.
Yes, we have excellent data on that. Studies have shown that when you see highly specific patterns, for instance, multiple non-contiguous perfusion defects that also show associated FDG uptake, plus evidence of extracardiac FDG uptake, the diagnostic performance is extremely high. One study showed 83% sensitivity and essentially 100% specificity with that combination.
So that powerful combination is often what's needed to confidently move a patient up the likelihood scale, maybe into that highly probable category, even without a biopsy.
Exactly. It's that integration of findings that strengthens the diagnosis in the absence of tissue proof. #TAG-V, diagnostic algorithms, continuum of likelihood, and differential diagnosis.
Okay, let's circle back now to the diagnosis itself and that continuum. The definitive gold standard diagnosis, pathway 1, still requires getting that direct histological confirmation right. Finding those specific non-caseating granulomas in a sample of myocardial tissue obtained via endomyocardial biopsy, or EMB, that puts the patient squarely in the definite CS category.
That's the historical definition, the gold standard on paper. But as we've discussed, it's significantly undermined by the patchy nature of the disease. An unguided EMB, just taking random samples from the right ventricle typically, has a notoriously limited sensitivity, often quoted around only 20%.
20%, that's really low.
It is, because the biopsy forceps might simply miss the small clusters of granulomas entirely. It's often described as like searching for a needle in a haystack, or maybe a few needles scattered in a very large haystack.
But targeting the biopsy using imaging guidance can improve that yield quite a bit.
Yes, significantly. Using guidance from electroanatomic voltage mapping, which identifies scarred areas, or targeting areas that look abnormal on PET or CMR, can increase the diagnostic yield up to maybe 40% to 50%. That's better, but still means you miss it half the time or more.
And critically, even a negative biopsy taken from a targeted area still doesn't completely rule out the disease.
Exactly. That inherent limitation of biopsy is what really drove the development and adoption of the structured diagnostic algorithms that integrate clinical, imaging, and pathological criteria, as summarized by major societal guidelines like those from the Heart Rhythm Society, HRS, the World Association of Sarcoidosis and Other Granulomatous Disorders, WASOG, and the Japanese Circulation Society, JCS.
And you mentioned the recent Japanese guideline is unique in one aspect.
Yes, it's noteworthy because it's the only major guideline to explicitly include a dedicated imaging-based diagnostic algorithm specifically designed for suspected isolated CS cases, where you don't have any biopsy-proven extracardiac evidence to lean on. And it doesn't strictly require biopsy confirmation for diagnosis.
Which reflects the reality of clinical practice for many complex cases.
It really does. Most specialized centers, especially when faced with likely isolated CS, will often rely on a compelling combination of clinical presentation and advanced imaging findings to justify starting immunosuppressive treatment, rather than insisting on an elusive cardiac biopsy first.
Okay, let's focus now on how the AHA statement embraces that continuum of likelihood, largely based on the WASOG construct. We know definite CS requires the positive histology. What distinguishes highly probable CS from merely probable CS? It seems to hinge on having confirmed disease outside the heart.
That's a key differentiator, yes. The distinction really relies heavily on whether you have biopsy-proven extracardiac sarcoidosis, ECS confirmed, and also on the synergy between the two key imaging modalities, CMR and PET. To reach the highly probable CS category, you essentially need 4 pillars to align strongly. First, you need that confirmed ECS from another site. Second, you need clinical findings consistent with CS affecting the heart, like the heart block or VAs we discussed. Third, you need typical supportive findings on either CMR or FDG-PET. And fourth, critically, you need to have reasonably excluded other common causes for the patient's presentation.
So having that confirmed ECS really boosts the pretest probability, allowing you to reach highly probable with strong clinical and imaging support.
Exactly. It gives you much more confidence. Now, the probable CS category allows for a bit more flexibility, acknowledging how difficult it can sometimes be to get that definitive ECS confirmation or dealing with isolated cardiac disease.
How does that work?
You can reach probable CS in a couple of ways. One path is if you do have confirmed ECS, plus either relevant clinical findings or typical imaging findings. Or, and this is the pathway that's really critical for a suspected isolated CS, you can achieve a probable diagnosis without confirmed ECS if you have characteristic positive findings on both advanced imaging modalities, typical scar on CMR, and active inflammation on FDG-PET, plus 1 or more relevant clinical findings, again, after excluding other plausible causes.
So in isolated cases, the combination of the SCAR map, CMR, and the FIRE map, PET, essentially acts as a substitute for having the systemic pathology confirmation.
It's a good way to think about it. The combined weight of the imaging evidence alongside the clinical picture pushes it into the probable category, often justifying treatment initiation.
Now, in all these categories, that phrase, exclusion of other causes, is doing a lot of heavy lifting. And we know CS is famously called the great masquerader.
Absolutely. The differential diagnosis is a huge clinical hurdle, particularly in those cases of clinically isolated CS, where you don't have the systemic context. We absolutely have to differentiate CS from lookalike conditions. For instance, genetic cardiomyopathies can present very similarly, with arrhythmias or heart failure. And here's a really startling finding the statement cites. In one published study looking back at patients initially diagnosed with isolated CS, subsequent genetic testing actually led to reclassification in 5 out of 16 cases. They turned out to have a genetic cardiomyopathy instead.
Wow, that's nearly a third in that small cohort. That's a powerful argument for considering genetic testing, isn't it? And taking a really detailed family history.
It really is. It underscores the recommendation for considering genetic counseling and obtaining a thorough 3-generational family history in anyone presenting with suspected isolated CS, especially if you don't have definitive biopsy proof. You absolutely want to avoid inappropriately treating a primarily genetic condition with long-term immunosuppression.
Makes sense. What else is high on the differential list?
Another critical one to rule out, especially in patients presenting very acutely or with rapid deterioration, is giant cell myocarditis, GCM. This is a different, often much more lethal, rapidly progressive form of inflammatory heart disease.
How do you tell them apart?
While GCM can present similarly, VAs, conduction disease, even cardiogenic shock, it requires specific exclusion, often urgently via biopsy if possible. Pathologically, GCM is distinguished by a more diffused inflammatory infiltrate and the presence of characteristic multinucleated giant cells, different from the discrete granulomas of sarcoidosis. The treatment differs, and the timeline for intervention in GCM is much, much more urgent.
Okay, so given all this complexity, the tricky diagnosis, the broad differential, the need for a multidisciplinary team approach seems absolutely essential right from the beginning.
Paramount. It really is. Hashtag BACs. Management and treatment strategies.
All right, let's say we've navigated the diagnostic maze, and we've landed on a diagnosis of definite or highly probable CS, especially if the patient is symptomatic. The next step is treatment, generally involving immunosuppression. How is the standard of care decided here, given, as you mentioned, the lack of robust RCTs?
It really comes down to expert consensus derived from decades of observational data, cohort studies, and registry data. Generally, the recommendation is to initiate treatment in patients with definite and highly probable CS who are symptomatic or have concerning findings like significant arrhythmias or worsening heart function.
What about those in the probable category?
For patients falling into the probable category, the decision to start potent immunosuppression requires a really careful, individualized discussion about the potential risks versus the potential benefits. You have to weigh the remaining diagnostic uncertainty against the seriousness of the clinical presentation and the significant side effects of the drugs involved. Hashtag A, immunomodulating agents. The tiered approach.
Okay, so the first-line therapy is almost always corticosteroids.
Yes. Corticosteroids, typically prednisone or an equivalent, starting at a moderate dose like 30 to 40 milligrams per day, is the standard initial approach to quell the acute inflammation.
Are there situations where you'd use much higher doses?
Yes, we might escalate to higher intravenous doses, sometimes pulse doses up to 1,000 milligrams of methylprednisolone per day for a few days, but that's typically reserved for life-threatening situations, things like cardiogenic shock or incessant ventricular tachycardia, VT storm, often in the very acute setting before we've even fully ruled out something like giant cell myocarditis.
But corticosteroids, while effective initially, come with a major long-term headache: the relapse problem. The statement quotes relapse rates as high as 75% when steroids are tapered. That's huge.
It is a massive clinical challenge. 3 out of 4 patients may experience a symptomatic relapse or worsening inflammation on imaging as you try to wean down the steroids. This high relapse rate is precisely why most patients cannot be managed with steroids alone long-term.
So that forces you pretty quickly onto second-line agents, the so-called steroid-sparing drugs.
Exactly. The primary goal then becomes finding an alternative or additional immunosuppressant that can maintain control of the inflammation while allowing you to significantly reduce or even eliminate the long-term steroid dose. This minimizes the well-known toxicities of chronic steroid use, things like osteoporosis, weight gain, mood changes, increased infection risk, diabetes. The list is long.
What are the go-to second-line agents?
The commonly used second-line steroid-sparing agents include drugs like methotrexate, mycophenolate mofetil, MMF, azathioprine, or sometimes leflunomide. These are typically added to the regimen for patients who experience relapse during steroid taper, or for those who show evidence of ongoing active inflammation on follow-up PD scans. despite the initial steroid course.
And if the inflammation still persists despite adding one of those second-line agents, then you move to a third line, often involving biologic drugs.
Yes, that's the next step of the tiered approach. Third-line therapy often involves tumor necrosis factor alpha TNF antagonists such as infliximab or adalimumab. These are powerful anti-inflammatory biologics.
But there's a specific caution mentioned with these TNF agents in heart failure.
Yes, a very important one. Prior large clinical trials looking at these specific agents, infliximab and etanercept, another TNF inhibitor, in patients with moderate to severe heart failure not caused by sarcoidosis, actually suggested potential harm worsening HF symptoms or increased mortality.
Okay.
Therefore, the AHA statement emphasizes that these TNF antagonists must be used extremely carefully, with heightened vigilance and close monitoring, particularly in CS patients who already have significantly reduced heart function, specifically defined as NYHA Class 3 or 4A heart failure symptoms. The potential benefit in controlling sarcoid inflammation has to be weighed very carefully against this potential risk of worsening the underlying heart failure.
So throughout this entire process of adjusting therapies, monitoring the response is key, and that relies heavily on follow-up imaging, particularly FDG-PED.
Absolutely. Assessing the response to treatment is really a dual-layered process. You look for clinical resolution. Are the patient's symptoms improving? Are arrhythmias less frequent? Is heart failure getting better? And you pair that with objective evidence of reduced inflammation, which is primarily tracked using serial follow-up FDG-PT scans. These are typically performed at intervals of maybe 3 to 6 months during the active phase of treatment adjustment to see if those hot spots in inflammation are cooling down.
So it's this iterative process. Treat, scan, assess, adjust. Treat, scan, assess, adjust.
Exactly. And this complex iterative process really highlights one of the biggest remaining gaps in our current knowledge base. We still lack that high-quality randomized trial evidence to definitively tell us the optimal duration for these potent drugs, or even the best sequence in which to use them. Much of it is still based on expert experience and observational data. Hashtag heart failure and advanced therapies.
Now, shifting focus slightly to managing the consequences of the inflammation, the structural damage, and the resulting heart failure. The approach here seems to be based mainly on extrapolating from standard heart failure guidelines.
That's largely correct. For managing the heart failure phenotype of CS, we rely on applying the standard pillars of guideline-directed medical therapy, GDMT, that we use for other cardiomyopathies. That means maximizing tolerated doses of beta blockers, ARNIs, angiotensin receptor neprilysin inhibitors, MRAs, mineralocorticoid receptor antagonists, and now SGLT2 inhibitors.
But despite optimal immunosuppression to control the inflammation and maximizing GDMT for the heart failure, some patients unfortunately still progress to advanced end-stage disease.
Yes, sadly that does happen. The scarring process can become irreversible and extensive, leading to refractory heart failure.
What's the outlook for those patients who might need advanced therapies like a left ventricular assist device, LVAD, or even a heart transplant? Is CS considered a contraindication?
That's a really important question for referral centers. And interestingly, the data suggests that outcomes for appropriately selected CS patients who undergo heart transplantation are generally similar to, or in some series, possibly even better than, outcomes for patients transplanted for other types of cardiomyopathy.
Better. That's surprising, given the ongoing systemic inflammatory potential.
It is somewhat counterintuitive, but that's what some large registry data suggests. So CS itself shouldn't be seen as an absolute contraindication to advanced therapies like transplant. However, this is also where we encounter one of the most sobering statistics, really reflecting how often the diagnosis is missed until the very end stage. The statement notes that the diagnosis of sarcoidosis is frequently unrecognized until the patient's native heart is removed and examined by pathology at the time of LVAD implantation or heart transplantation.
Wow.
Clinical misclassification, meaning they thought it was something else entirely, has been reported in up to two-thirds, 66% of CS patients only diagnosed after their heart was explanted.
That's astonishing. It truly underscores the immense difficulty of making the initial diagnosis before things get to that critical stage.
It really does.
And post-transplant, is there a significant risk of the sarcoidosis coming back, recurring in the new donor heart? Does that influence long-term management?
Yes, the risk of CS recurrence in the transplanted heart, the allograft, is real and well documented. Because of this risk, most transplant programs will maintain the patient on at least a low dose of prednisone indefinitely post-transplant, in addition to their standard anti-rejection immunosuppression regimen, specifically to try and mitigate that risk of sarcoid recurrence.
So it requires ongoing vigilance and often collaboration between the transplant team and sarcoidosis specialists, even long after the transplant surgery itself.
Absolutely. Long-term multidisciplinary care remains crucial. Hashtag tag 7, arrhythmia management and ICD recommendations.
Okay, let's pivot to arrhythmia management, which is just absolutely central to survival in cardiac sarcoidosis. As you said, the granuloma formation can directly attack the heart's electrical system, and the resulting scar creates the perfect substrate for dangerous ventricular rhythms.
That's right. Conduction system disease is incredibly common. As we mentioned, it can be the presenting feature. Up to maybe 43% of individuals might have something like a right bundle branch block on their ECG at the time of diagnosis. And as we discussed, the sarcoid lesions frequently target that intraventricular septum, which is prime real estate for the AV node and the His-Purkinje system. That's why high-grade heart block is one of the major red flags for CS.
And it's crucial to understand that individuals who develop heart block caused by CS seem to face a kind of double jeopardy, right? There's the risk from the block itself, needing pacing, but also an unusually high underlying risk of subsequent ventricular arrhythmias and sudden cardiac death.
Absolutely.
Yeah.
They're at intrinsically higher risk for life-threatening VAs compared to someone with, say, age-related degenerative heart block. Therefore, the standard management approach is tailored specifically to address this dual risk. Even if the heart block resolves after immunosuppressive treatment, which can happen if it was caused by active, reversible inflammation, though recovery is variable and depends on how much permanent fibrosis occurred, the recommendation is often still to implant an ICD, not just a simple pacemaker.
So even if pacing isn't strictly needed anymore after treatment, the underlying disease process still warrants ICD protection.
In many cases, yes. The consensus recommendation, rated as Class 3 in the guidelines, is that for patients with CS who have a guideline-based indication for permanent pacing, like persistent high-grade AV block, the implanted device should generally be an ICD because of that concurrent high risk for ventricular arrhythmias. You want to provide pacing support and protection against sudden death.
That makes sense. Okay, now shifting to primary prevention of sudden cardiac death, putting in an ICD in patients who haven't yet had a life-threatening arrhythmia but are deemed high risk, we have to reiterate that foundational shift in thinking. Relying solely on the LVEF, the ejection fraction, is insufficient and potentially dangerous in CS.
It is absolutely insufficient. We cannot just use the standard LVEF 35% cutoff that we use for ischemic or non-ischemic cardiomyopathy and assume it captures all the high-risk CS patients.
And this is where cardiac MRI, and specifically the presence of late gadolinium enhancement, LGE, really redefines our understanding of risk stratification.
Exactly. LGE on MRI serves as that crucial structural marker of risk. Its presence is an independent predictor of future ventricular arrhythmias and death, regardless of what the ejection fraction number is. The data supporting this is quite compelling. The statement references a large study showing that the annual event rate, death or sustained VA, was about 20 times higher in CS patients who had LGE compared to those who did not have LGE. The numbers were roughly 4.9% per year versus only 0.2% per year.
20 times higher risk just based on the presence of scar. It's a huge signal.
It really is. The mere presence of that scar tissue, especially in those critical locations we talked about, fundamentally dictates the future arrhythmic risk.
So let's detail the specific ICD guidelines for primary prevention in CS as laid out in this AHA statement. How do they incorporate LGE and other factors beyond just LVEF?
Okay, so the standard class I recommendation, the strongest level of recommendation, still applies to CS patients who meet the traditional criterion. An LVEF of 35% or less despite optimal medical therapy. That hasn't changed.
Right.
The critical addition, the real safety net for CS, is the Class TI recommendation for primary prevention ICD implantation in patients who have an LVEF greater than 35%.
Okay, so for those with seemingly preserved or only mildly reduced pump function, what qualifies them for this Class TI recommendation?
This Class TI recommendation applies if a patient with LVEF 35% meets one or more of the following criteria. First, if they've had unexplained syncope, fainting, that's thought to be potentially arrhythmic. Second, if they have evidence of significant myocardial scar identified by LGE on cardiac MRI, or alternatively extensive active inflammation on FDG-BPT. Third, if they have an indication for permanent pacing because of sarcoid-related conduction disease, as we just discussed. Or fourth, if sustained ventricular tachycardia is inducible during a formal electrophysiology EP study.
So it's a much broader set of criteria incorporating syncope, imaging findings of scar or inflammation, pacing needs, and EP study results to identify high-risk patients even if their LVEF looks okay.
Exactly. It's a much more nuanced and robust framework designed to ensure we adequately protect CS patients from sudden cardiac death, recognizing that LVEF alone just isn't a reliable enough risk marker in this specific disease. Hashtag Tag 8, multidisciplinary care and future directions.
Now, given everything we've discussed, the multi-organ nature of sarcoidosis, the complexity of the diagnosis, the tricky balance of immunosuppressive drugs, the highly technical nature of the imaging and arrhythmia management, the statement correctly and strongly emphasizes that this disease absolutely requires a dedicated, multidisciplinary team approach.
It's non-negotiable, really. This is a disease far too complex for any single specialist, whether it's a cardiologist or a pulmonologist, to manage effectively in isolation. The essential core team needs to include several key players. You need advanced heart failure cardiologists, specialized cardiac electrophysiologists, EP docs, advanced cardiac imagers who are truly expert in interpreting both CMR and FDG-PET in this context. You absolutely need pulmonologists involved, since lung involvement is so common and often provides the initial diagnosis. Rheumatologists are often key for managing the systemic aspects and the immunosuppression. And increasingly, specialized pharmacists play a crucial role in navigating the complex drug regimens, interactions, and side effect monitoring.
That makes perfect sense. When should a general cardiologist or maybe a community specialist think about referring a patient with suspected or confirmed CS to a dedicated subspecialty center that has this kind of integrated team?
Referral to a specialized center is strongly indicated in several situations. First, if there's significant diagnostic uncertainty, maybe they're stuck between possible and probable on that likelihood continuum and need further evaluation or a second opinion. Second, if the patient requires second or third line immunosuppression because their disease is refractory, meaning it isn't responding adequately to standard first-line prednisone therapy, managing drugs like methotrexate or TNF inhibitors requires specific expertise. And third, referral is definitely warranted if the patient develops severe cardiac manifestations, such as recurrent ventricular tachycardia despite initial therapies, or if they progress towards end-stage heart failure requiring consideration of advanced therapies like LVA or transplant. Specialized centers simply have more experience and the integrated infrastructure needed to manage these most complex and high-risk cases.
Okay. Now, despite the incredible progress in imaging and diagnosis that's really highlighted in this scientific statement, it also points out there's still significant knowledge gaps, areas where we need more research to optimize care.
Yes, absolutely. And perhaps the biggest gap, which we touched upon earlier, remains the critical lack of high-quality evidence from randomized clinical trials. RCTs. We desperately need RCTs to guide the optimal timing, the best choice, and the ideal duration of these various immunosuppressive therapies.
We're still making educated guesses on some fundamental treatment questions.
To a large extent, yes. We don't definitively know the best sequence for second and third line agents, how long treatment needs to continue, or even precisely which patients benefit most from aggressive long-term immunosuppression versus a more limited course. It's still largely guided by observational data and expert consensus, which isn't ideal.
And there's also that lingering, perhaps ethical question about treating asymptomatic disease detected only on imaging.
That's another major unanswered question. It remains unclear whether we should routinely be treating individuals who are completely asymptomatic, feel perfectly fine, but are found to have evidence of myocardial inflammation, say just hot spots on an FDG-PT scan, without any associated cardiac dysfunction or arrhythmias.
The dilemma being, if we treat them early, can we prevent the development of irreversible scarring and potentially reduce their long-term risk of heart failure or sudden death years down the road? Or are we just subjecting them to the risks of immunosuppression unnecessarily?
Exactly. Answering that question definitively will require large, prospective, probably multi-institutional studies following these patients over time to really understand the natural history and the impact of early intervention based solely on imaging findings.
So looking ahead, there's still much work to be done, which brings us to a final thought. Given the clearly established high risk associated with myocardial scarring that LGE on CMR, even in patients who seem stable and maintain normal heart function for a long time, this raises a really important question for the future, doesn't it?
It certainly does.
How can we leverage emerging imaging technologies, maybe advanced techniques like radiomics or artificial intelligence applied to CMR and PT scans, How can these be developed and standardized across different centers to help us get much better at predicting and maybe ultimately preventing sudden cardiac death in these seemingly stable CS patients, long before their LVEF ever drifts down towards that traditional 35% danger zone? Finding those subtle markers of impending electrical doom, that seems like a critical frontier.
That's a fantastic point to end on. Improving our ability to non-invasively identify the highest risk individuals earlier, even with preserved function, is absolutely crucial for improving long-term survival in this challenging disease. We need better tools to see the future risk hidden within the images. Thank you for watching The Funnel Effect.